Hello, everyone, and thank you for joining us today. We are in the second session of the NSF Prepare workshop, which focuses on data and how data can be harnessed to improve our preparedness for future pandemics. We have three keynote speakers today: Dr. Marcel Salathé from EPFL, Dr. John Brownstein from Boston Children's and Harvard, and Dr. Jure Leskovec from Stanford. And without further ado, let me welcome our first speaker, Marcel Salathé. Marcel is an associate professor at EPFL, where he heads the digital epidemiology lab. Marcel is an epidemiologist by training, and he works at the intersection of health and computer science. He has obtained his PhD from ETH Zurich, and then he spent a couple of years as a postdoc in Stanford, and later joined the faculty of Penn State University. Marcel is the initiator and co-organizer of the Applied Machine Learning Days. Today, it's probably the largest conference on applied machine learning in Europe. And he has also founded the AI4Nutrition.org project, which is a suite of AI-based platforms, mobile apps, and datasets for improving personalized nutrition. Marcel is the president of the steering committee devoted to COVID-19 of the National Science Foundation, and he is a member of the Swiss National COVID-19 Science Task Force, where he leads the Digital Epidemiology Expert Group. Before we proceed with the talk, let me just remind you that since we are in the virtual setting, we'll defer all the questions until the end of the three talks in the session. Please post your questions in our YouTube channel in the comments box or via Twitter. We have the Twitter handle all in capitals, NSF_prepare. And we'll collect the questions, and I will post them to the speakers in real time. So please welcome Dr. Salathé, who will talk about digital contact tracing.
All right, thank you, Evgeny. I'm going to share my screen, and I hope you can see the slide now.
Mm-hmm. Yep.
Good. So thanks very much for the invitation. Pleasure to be here. I want to talk a little bit about digital contact tracing and especially the lessons learned. And yeah, I mean, I think we all had our own time of craziness in this pandemic, from not even talking about the personal, but just the scientific. Mine certainly was in this space when it comes to digital contact tracing. We developed a protocol for it, and then apps were rolled out in Switzerland, of course, around the world. And now the big work is mostly related to measuring the efficacy of those apps. So I think this is now common sense, but it's nevertheless, I guess, worth repeating, right? That if you want to get a hold of this virus, you have to cut transmission chains, but you have to cut them when people are contagious, not only when they're symptomatic. And that's, of course, a key difference between this virus and other viruses, in particular SARS-2. And this is where contact tracing comes in, to find these contacts and to cut these potential transmission chains. And the way this works now, again, just because it still seems it's not quite as broadly understood as I would like it to be, is you use a toy model like this network, right? And you consider a person getting contagious but not yet symptomatic. So that's unfortunately a few days before symptoms onset, people are already contagious. Now, eventually this person gets symptomatic, but at that point, it's likely they have already infected other people. So if you just focus your attention now on isolating symptomatic people, that's not going to be sufficient. You will lose control over your outbreak. And ideally, right, you would put these people in quarantine, and then you could stop an outbreak. And if you don't do that, if you don't do it well, if you don't do it precisely, if you don't do it fast enough, well, the alternative is that you do this in a non-targeted way, which means everybody goes into quarantine, aka lockdown, and that's what we always want to prevent. So the way we set this up initially, right, from a conceptual perspective, is here shown with Alice, who goes about her day. She has contacts, right, over time. Eventually, she gets infected. It doesn't matter at the moment here how. and she becomes contagious without knowing it because, you know, she has no symptoms. And then a few days later, she does actually get symptomatic, and you know, she stays at home, obviously isolates, makes a test, she's positive. Now contact tracing kicks in. There's traditional contact tracing. She also uses this contact tracing app. So we sort of go back in time and now try to evaluate who were the contacts of Alice in her contagious period. And there can be 4 cases, right? She can get contacted by traditional contact tracing only, by an app only, or by both, or by nobody. And so, well, it doesn't matter, right? As long as you get contacted and you play along, you go into quarantine. And that's a good thing because, you know, parts of these contacts will actually then eventually develop symptoms. But if that happens in due time, these will be dead ends from a viral perspective. So the way we figured this should work is through proximity, and proximity in particular in this case would be looked at from a Bluetooth perspective. So phones would broadcast the signal via Bluetooth that they're there, of course, right? This would be all in, you know, encrypted and so on. But for the purpose of the example here, we just assume A meets B, you know, for a sufficient amount of time, sufficiently close. Both phones make a record of that interaction. Later, right in the week, another phone that has a close interaction with A's phone. And so again, this will be recorded and so on. So basically it's like having a logbook, but totally encrypted, and everything stays on your phone. And is continuously deleted as it becomes irrelevant from an epidemiological perspective. Now, critical, right, is what happens if A gets sick and is tested positively. So there's a critical difference now in what you can do. What we call the central model is the model where you say, well, you know, let's intuitively, the smart thing seems to be to upload the fact that A has been in contact with B, C, and D to a server. And then on that server, you can make a decision, you know, should I contact B, C, and D? I mean, in this case, simple example here, right? It's yes, because that's the goal here. And you inform B, C, and D, and they get a notification. And that's the epidemiological goal. The problem here is that the server now knows, right, that B, C, and D had contact with someone else. And over time, you could develop contact networks. Data could be used for other purposes, as we're actually now seeing in some countries that are using centralized systems. Users lose control over the data. You're accidentally building an infrastructure that can be misused for many surveillance purposes that have nothing to do with this pandemic. So we wanted to prevent that, and that's why we developed the decentral model. So here in this model, rather than A uploading the fact that there's been a contact with B, C, and D, we're just uploading the fact that A is infected. So that means the contact information always stays on the device. Now that's a little computationally more intensive because now you have to broadcast this information to all the phones out there, right? But then the phones can make locally on their own devices, can make the decision, have I been in contact for sufficiently long, right, with A, and then, you know, raise an alert. And so here the consequence would be the exact same thing, namely B, C, and D get notified, but you don't have any critical information on the server. And that's great from a privacy perspective, right? Because the server, if it gets hacked or if it gets misused for other things, it doesn't matter because it's essentially just a dumb server that's passing on non-sensitive information. This is why we call it decentral. So initially, when we started working on these ideas, there was a project in Europe that was called PEPPT, which stands for Pan-European Privacy Preserving Proximity Tracing. Now, eventually, right, there was a sort of a split in the group because we disagreed on how transparent this should be and on this centralized versus decentralized approach. And the group that wanted to be fully transparent from the beginning and wanted to have a decentralized approach split off into this DP3T group. That DP3T protocol eventually made it into Apple and Google's exposure notification. And yeah, because we were early there, we in Switzerland were the first national government EN exposure notification app to launch. But you know, at that time, many then launched within days and weeks and months. So maybe, you know, brief parentheses here in terms of development of this protocol. I mean, this is a classic case of a challenge of the future, in my view, right? There's going to be crises, and you need expertise from multiple groups, right? In multiple domains. And in this case, technology and epidemiology. And I've seen, observing the space a little bit, I've seen a lot of groups that, extremely good intentions, but there wasn't always both expertise around, and that would sometimes lead to, proposals that were difficult really to implement. And here at EPFL, I know this is true also in many universities, we were in the fortunate situation that epidemiologists were already talking to computer scientists, right, years before this crisis unfolded. So, when the crisis hit, we could just walk over these bridges and immediately kick into action. You cannot build these bridges when the crisis hits, right? When the flood comes, you already need them. And this is hard because even though in science and in academia, right, we keep saying, transdisciplinary work is the future of science and it's of critical importance, we make it incredibly hard still for transdisciplinary scientists when it comes to incentives. There's still few journals, right? Although there are more now, but there's still few transdisciplinary journals. Grants are still hard to get for this kind of work. There's few prizes, right? There's prizes for computer science and epidemiology and science and physics and chemistry and what have you. But for this interdisciplinary stuff, it's not. There's very little. And I guess at the core of this problem is that work ultimately has to be evaluated and reviewed, and that is normally done by single domain experts. And there you have the problem that either they dismiss the other field and think, it's not important, or they don't know the other field too well and say, I cannot really judge this. So it's a difficult problem. Unfortunately, I don't have a good solution, but it's something we should recognize. Now, when it comes to building this technology, right? So because we're looking at the epidemiological impact, but we're also looking at the preservation of privacy. Of course, we could just say, we're just going to focus on one of them, end of story. But that's not really practical, right? You can't really say, I just care about the epidemiological impact. Preservation of privacy be damned. You shouldn't do this, especially not in a crisis, even though there are people who are trying to do this. And so, I think this trade-off, if you think about it in this way, I think it would be the wrong way to think about it. Rather, let's get all the expertise together and think how we can shape this curve so that it looks different. More something like this, right? Because if you manage with technology to bring the curve to this shape, you can sort of find a spot there where you're comfortable, right? Pragmatically speaking, where you say, well, this doesn't have the strongest epidemiological impact we could theoretically have, but it has a very strong epidemiological impact. And it has that with acceptable privacy risks. So this is a pragmatic solution. And those of you, right, who are working with pragmatic solutions and who are proposing them, you know exactly what's going to happen next, right? The non-pragmatists are going to show up at your door and they're going to say, what the hell are you doing, right? If you just look at it just purely from the privacy preservation angle, well, this is not the best solution from a privacy perspective, and you get criticized there. The epidemiologists come to you and say, what are you doing, right? This is not the best solution from an epidemiological perspective. All of this happened even worse, right? All of a sudden, privacy experts, started talking about the epidemiological effect, but that's a story for another talk. But this is what we felt we should do. We should be pragmatic and we should do this fast. So, if you want to learn more about this particular protocol, it's the papers on the archive. There's obviously a Wikipedia page. Of course, we were extremely pleased to learn that Google and Apple would eventually come out with this exposure notification framework, and even stated publicly that basically they adopted this DP3T solution as their basis, right, for this protocol. So, coming slowly towards an end. So, what were the challenges, right, looking back at this? So yeah, as I said, right, everything was challenging, but there's some things that were easier or harder than other things. So easy, at least from my perspective, thankfully, was getting the right people together locally and figure out how to do this. But then, it was actually quite hard to convince everyone else that decentral is the way to go. And as an epidemiologist, this was particularly hard for me because my epidemiology colleagues were saying, what are you doing, right? We need more data. We need more data, right? You're standing in the way here. And I was trying to argue, no, we can actually have the same, reach the same goal, but we don't accidentally build this huge surveillance machine, which later will anyways be repurposed. Easy was building the app. I mean, building such apps, is never an easy thing, but comparatively speaking, it was easy. Whereas what I found harder is then to come to this point, right, where you realize now you need to build a legal framework to get this out the door, because we obviously live in a place where government can't just do what it wants, but it needs legal justification, and so that turned out to be a little harder than I thought. But anyways, it happened quickly, and eventually we were ready to go. Again, making the app work technically, that was the easy part. Again, right, nothing is really easy, but comparatively speaking. But then making the processes around it work, that was the tricky part. Because right, before the app can actually kick in and unfold its epidemiological impact, there's a couple of steps that need to happen before, testing, delivery of COVID codes, and so on. So making sure that these processes work in the public health context that you find yourself in, that was much, much harder. And in Switzerland, we had a lot of delays in the beginning because these codes weren't delivered on time because the public health system wasn't ready. Final question, right? Does it work? This is actually harder than it seems, because the privacy preserving features of this system, of course, also make it then relatively hard to estimate its efficacy, but you can do it. In Switzerland, we did a bit of this in the beginning in the summer, but we don't have a lot of data because we didn't have a lot of cases back in the summer. And then when the second wave hit in the fall, the system collapsed very quickly, not the digital system, but the traditional system. And the healthcare system essentially stopped reporting whether people were using the app because they were just busy with other things and they weren't prepared. And so we don't have the data now. But from very early and local cohorts, we know that there was a substantial speed gain of 1 to 2 days. This may not sound like a lot, but right, think about the fact that you need to be faster than this virus just a few days, right, to really beat it. We saw efficacies comparable to traditional contact tracing. And then also now we have this data from the UK, right, that is, I think, super, super convincing. And it just so happens that this came out today. Rather than going into the details here, I mean, it came out in Nature. It's a great paper, and Christoph Fraser, which you should really follow if you're interested in this kind of work, just has this fantastic thread on Twitter. The app works, and they estimated in England and Wales that it prevented several 100,000 of cases in just 3 months back in the fall. So, next time, sorry to misuse your logo here a little bit, but this is really where it's at, right? Rather than inventing new systems and trying to convince the world that this is the right way to do it and being caught in this extreme hurry, we could have developed systems like this before, and we should do this in the future. It's a question of preparation. Thank you very much. And I'm going to stop the sharing here so that John can start.
Marcel, thank you very much for your insightful talk. It is amazing to see the impact. I think the previous numbers I have seen were tens of thousands of cases prevented, and seeing that this has potentially saved hundreds of thousands of people is just amazing proof to your foresight in starting of this work before the pandemic. With that, let us proceed to our second speaker today, Dr. John Brownstein. John is a professor of biomedical informatics at Harvard Medical School, and he is also the Chief Innovation Officer of Boston Children's Hospital. He directs the Computational Epidemiology Lab and the Innovation and Digital Health Accelerator, both at Boston Children's. John has been trained as an epidemiologist at Yale University And he also serves as a co-founder of digital health companies Epidemico and Circulation, and he is also the BBC News medical contributor. So please welcome Dr. Brownstein, who will be talking about digital epidemiology and the COVID-19 pandemic.
Great. Thank you very much. You can see my screen, right?
Yes.
Okay, great. Well, it's really an honor to talk to this group. Thank you, Evgeny. And it's nice to follow Marcel, two people that I highly recognize as leaders in the digital health and epidemiology space. So I'm really honored to be next to you guys as I talk a little bit about some of the work that we've been doing in terms of the pandemic. Now, Marcel gave a great presentation on the digital applications of contact tracing. My lens is a little bit more towards the opportunities around surveillance. Late in 2019, our systems were tracking online news media and detected a news source talking about a mysterious illness in Wuhan. This was the first sort of information source about what was taking place outside of China at the time. We fed that information to the WHO, and then quickly our team started spending night and day building tools to essentially track the spread of this virus as it moved around the world. And of course, we're familiar with many tools that have sprouted out, trying to figure out, especially in the early parts of this pandemic, how to do a better job of organizing the vast amount of data that was coming through many different channels, but especially in the early parts of the pandemic, trying to piece together how this virus was spreading. And then of course, all the characteristics that we needed to understand in order to implement the right types of interventions. I'll just take a little step back. As we talk about digital epidemiology, my work is focused on this idea of the digital exhaust. What are the information streams that people leave behind in their interactions with day-to-day technologies, whether that's social media, search data, news media, whatever information is out there that we can tap into. We've been building tools over the last 15 years now with this idea of organizing all that content, which we've termed, the digital phenotyping. Many examples in other domains. We've applied it to infectious disease specifically to get early insights about diseases in populations through people's disclosures of symptoms or other types of data streams. And the idea is that you could provide early insights to public health about what was taking place in a population. On top of that, the ability of tapping into these information streams at a global level means that you can do some things in real time, but at scale. And that, of course, is an incredibly challenging proposition when you're a public health department trying to get sort of global view of what's happening. Just the limited amount of information that is out there on a particular population means that it's really challenging to do with more traditional data streams. So our team has been focused on initially a tool called Health Map, which is this global tracking system that mines information across tens of thousands of websites across many languages with the idea of finding clues about disease events in populations. Our goal has been to identify alerts, and we've been doing this for many years with CDC and WHO, to find alerts in populations, early clues of a mysterious illness or some outbreak taking place that can shorten the time to a response. And that's through a combination of natural language processing, parsing out text from news articles or social media sites, looking for extracting particular terms of disease, of location, of species. Once you've organized all that massive amount of content, it means that you can actually build a living, breathing map of emerging infectious diseases across the globe at a scale that is very different from what traditional public health can give to you. And so over time, whereas this field of digital epidemiology has sort of been in the margins, has become more and more sort of central to our public health surveillance systems, to the point where official governments are using these for response. And we've seen especially that take place during this pandemic. So this is a view of the Health Map COVID tracking system. And yes, it provided some initial value, but the challenges of just mining news and social media meant that you could only get so much data. Yes, you could find early events in a particular population, but it sort of stopped short of giving really detailed, rich insights about what was happening in a population. And because of this, we started to think about possible collaborations. We started working with colleagues, Moritz Kramer at Oxford, Sam Scarpina at Northeastern, Rebecca Katz at Georgetown, Caitlin Rivers at Johns Hopkins, with this idea of how do you build a large-scale database of epidemiological information, line list of information to give you rapid, detailed epidemiological insight at the outset of a pandemic. We started doing this in a manual fashion, but clearly the opportunities became just overwhelming for us to collect, rich data sets to support response to the pandemic. And this is when we started coming together to think through, what do we do to build this map? And of course, many people are familiar with Johns Hopkins or other types of maps. Our goal was actually to not create aggregate case counts, but actually provide detailed insights of identified cases and associated demographic factors to really, truly provide that insight that was needed, especially in the early parts of the pandemic. We were lucky enough to have support from Google to really double down on this effort that we now call global.health, and have now built a repository of 160 million data points from across the globe through this combination of mining and crowdsourcing across the globe. Of course, I just mentioned the collaborations across multiple academic institutions and Google, as well as now Rockefeller. But the idea was, how do you build a data portal that provides open, rich information to respond to pandemics? And this is through curation, but also data parsing, cleaning, all being done in an automated fashion that then can push that data back to the open source community, researchers, policymakers, news. And so that data now lives on global.health. It's free and available. You can check it out and play with it. Huge amount of data that's now made available. And this is this rich, detailed data that can actually help support our ability to respond to the pandemic. This was an early paper we published in Science that showed that you could actually understand the impact of interventions like a lockdown on the trajectory of cases by looking at this data in combination with mobility information. And so early on, when we had very limited understanding of whether lockdowns work, this was one of those key pieces of information that gave us that insight that ultimately showed that China was able to control the cases through sort of these very extreme measures. Of course, the ability of collecting line list data can only get you so far. And so we started building crowdsourcing tools in addition to some of that line list information. We've been working on this idea of putting the public back in public health for many years, but it became super important, especially with limited testing in a population. You couldn't really get deep insights into what was taking place, what communities were getting hit hard with COVID without testing. And so we actually enlisted collaborators from a range of companies to come together and build essentially a crowdsourcing site in a matter of days. That turned into a platform called COVID Near You. It's actually called Outbreaks Near Me now because we rebranded. But the idea is that we brought in millions of people that were talking about their symptoms, their behaviors, their demographic features. So we could essentially get insights in who was getting hit and also essentially build a case definition for COVID, again, in the absence of having testing available to us. So essentially what we could do is through these hundreds of thousands of people that were reporting daily about their symptoms, we could basically essentially collect and assess COVID-like illness in populations. At the beginning of the pandemic, for instance, we wanted to understand age attack rates and which particular parts of the population were getting hit hardest. When we didn't fully understand that, clearly it was the older populations that were getting struck by this virus at large scale, especially the earliest parts. That obviously shifted over time, and through our data, we could start to be able to parse out sort of how the change in demographics was taking place, not only in age groups, but also in the difference between urban and rural areas. And because we had this rich granular data, we could start to ask a lot of different questions. Of course, the syndromic surveillance nature of this information allowed us to, for instance, look at, for instance, when we were hitting a next wave. So like when the first wave subsided, we could quickly detect the new wave that was emerging in the south and southwest of the US because we had this early insight, and again, because testing wasn't quickly available. But then we also had insights on other things, like for instance, what delay in care were people missing out on because of social distancing and stay-at-home orders? And what we found is, of course, many individuals were deferring care for a whole range of diseases, as simple as asthma to as severe as cancer. And so the kind of rich data you can collect from these survey-based tools is significantly different than, for instance, what you could collect from an electronic medical record. We then enlisted the help of SurveyMonkey, which many of you know, open survey-based tool, not open, but you can create open surveys that people can take. We essentially tacked on our Outbreaks Near Me survey onto SurveyMonkey surveys that were already in play to quickly get insights from hundreds of thousands of people on a weekly basis around a range of topics. Like, for instance, we want to understand behaviors across different subpopulations. If you had a flu shot, would you be more willing to socially distance? And that's probably everyone knows the answer is that yes, it is. You're more likely to social distance. But could you sort of understand like what impact we might have around travel and mass gatherings, say during a holiday? Over Thanksgiving, we found that about a third of households were looking to travel and interact with people outside their households. And of course, then that gave us real insights that we were about to see a real surge in cases, which we of course did in the US. I think probably the most fundamental value of this survey was in our ability to ask about mask wearing behavior. We collected almost 400,000 responses nationally at a county level that could tell us, what people's behaviors were with a variety of tasks and when they were willing to wear a mask. Through that data, because there was very limited national scale, high resolution data on masking, we could start to develop models. Like, for instance, communities that chose to take on masking were able to actually drive down transmission in communities. That might be super obvious to us, but of course, within the US, huge amount of debate around whether masking actually produced any value. And the answer is yes. And to probably nobody's surprise, we looked at the combination of social distancing through data from Google, as well as the SurveyMonkey mask wearing data, and the best combination of driving down transmission in the community clearly comes from the combination of those two things. High mask wearing, high social distancing drives down transmission. Again, no-brainer type results, but again, a lot of debate around whether these interventions really worked or not. We've now extended this work much more globally. This is a collaboration we have with Facebook. They've administered this incredible survey in collaboration with University of Maryland and CMU, where they're asking people daily about a range of symptoms, but also behaviors. And so these surveys have been deployed to millions and millions of people. What it allows us to do is quickly start to test out various symptomologies, looking at specifically defining COVID-like illness, but also identifying important signals across platform space, phase of illness. And clearly, as we start to validate this data across many countries, the opportunities for nowcasting and forecasting become incredibly valuable. Similarly, we launched a platform with Google Health Studies, where the first app on the platform, similar to the Apple Research Kit, was around respiratory health. And we're collecting data on influenza, coronavirus, but also non-specific illness. And the idea is both an ability to track COVID in communities, but also specifically understand specific behaviors that increase or decrease risk of developing respiratory conditions. And so very much absent from a lot of our work is the rich individual level detail, and these sort of health studies that sort of track and have a huge amount of input. The individual level will provide a level of granularity that we just haven't seen to date. A lot of our work also focused on access, this issue of trying to understand whether we're actually providing care in an equitable way. And obviously the answer is no, we were not. The people that were hit hardest by the pandemic highlighted existing disparities in our health systems. We started looking at early on around testing and the geographic positioning of where testing was in the community. And we essentially did network analyses to look at distances to test sites across the country. So how far one has to drive to get a COVID test. And not surprisingly, what we found is that there was high disparities in access, right? So median travel time to a testing site was of course correlated with lower population density, higher percentage of minority populations, uninsured populations. So just as much as the pandemic exacerbated disparities in outcomes, it also exacerbated disparities in access to testing. So again, this provided a map of sort of places where we needed to fill in some of the gaps in terms of truly getting insights and where we were seeing emergence events of COVID. The last thing I'll talk about is on the vaccination side, because our team has been working hard to essentially build better tools to support access to the vaccine. This is actually a tool that we took over. I know there's a lot of mention of Google here, not on purpose, but we took over a platform called the Flu Vaccine Finder, been running it since 2012 with this idea of making all the vaccine sites more visible and accessible and easier to access by the US population. We redeployed the platform for COVID vaccines. And this is now sort of a central part of the flow of information around vaccines, but it's the public site to where people can access vaccines. And in fact, Vaccine Finder relaunched last week, announced by the president as vaccines.gov. And if you go check out the website, you can see that you can quickly see which vaccines are available to you and the distance and who's in stock. It's also a text messaging service led by Twilio and a call center, all with the ability of trying to get improved uptake in the population. And so we have essentially partnered with Google and Google Maps and Waze, Facebook and Instagram. Apple Maps is now launching vaccine finder data as well. You can ask Amazon Alexa for where you can get the COVID vaccine. And all of that is with the objective of trying to improve, reduce those barriers to access. Even we announced yesterday that McDonald's is going to feature the website on its coffee cups. Uber and Lyft are going to give free rides. Regardless of that, we essentially have still this challenge. And as much as people can get are pretty close to vaccination sites, we have about 10% of the population that is still out of reach of the vaccine. And so we've done work around vaccine deserts with CDC to essentially show some of the big gaps. Of course, rural areas have major gaps in access, but so do urban areas where you see a divide between percent Black populations and lack of actual supply of vaccine. So even in a rich urban area, you have a huge divide in terms of access. And even when you start looking at distance, you have real challenges in terms of the drive times that people have to get to these vaccines. Clearly, rural areas, you have to go further. In those communities, people are willing to drive longer, but there's to a point. And if we start understanding sort of the disparities and issues in how we're allocating vaccine locations, we can start to remove some of those key barriers. In the US specifically, and actually around the globe, we of course have this issue of vaccine uptake. Obviously there's been an improvement since the summer when over half the US population wasn't willing to get the vaccine. That has improved really dramatically. So that's phenomenal, but there's still really a lot of variation, right? By age groups, younger populations aren't willing to get the vaccine based on your political party. You may not be willing to get the vaccine, and there's still some really persistent concerns that people have. And so it tells us that we're not doing the best job possible educating people about what vaccines can do for them and why they're low risk. And in fact, my colleague Marcel has spent a lot of years looking at vaccine hesitancy and rumors. So we worked for years on this topic. And one of those interesting things is with Johnson & Johnson, essentially we had a situation where actually there was a huge amount of preference for J&J because it was one and done vaccine. So on March 24th, before the pause, J&J was actually a favored vaccine. And then the pause happened. And the challenge is that we had many, many sites across the country with only J&J. So thousands of sites that only had J&J. And what happened with the pause? Well, essentially, the confidence for this vaccine dropped dramatically, and it's only started to go up a little bit, and that's mostly among men. So we have a real problem with this vaccine because it's never gone back to baseline even after it was unpaused. So a lot of challenges that we have in front of us in terms of getting that last mile, that uptake of the vaccine. Just a couple more slides. We also have this problem in the pediatric population. We're about to get approval of the 12 to 15-year-old group in the US, probably happened maybe already. I haven't looked at the ACIP meeting, but we have over half the parents of kids 12 to 15 who are still not interested in vaccinating their kids. And so if we consider population level immunity to include getting kids vaccinated, then we have this problem, and it only gets worse as you go down into the 5 to 11 and under 5 age group. So a lot of work to do around education. Now that may change with the approval, but right at this current moment, we don't have a majority of people looking to get their kids vaccinated. And then just one final thing, and this is a paper that we had come out a couple weeks ago. There's also a lot of confusion just generally in the population about interventions and the vaccines, right? There's over half the population that we surveyed doesn't fully understand when the vaccine is protective and that it's 1 to 2 weeks after the second dose. There's a lot of challenge in people fully understanding when you're protected, when you shouldn't wear a mask in public and indoors. So as much as there's been a huge sort of effort to get this vaccine out the door and deployed, the education and sort of hesitancy issue is still one that is very significant, in addition, of course, to these access issues that I've described. So with that, I'll thank everyone and look forward to the questions after this. Thank you.
Thank you very much, John, for your extremely comprehensive talk. It's amazing how much data you and your colleagues have amassed and analyzed. And I personally particularly appreciate the work you're doing on vaccines, quantifying the disparities and promoting the improved access and uptake. And with that, let us proceed to our third invited speaker for today, Jure Leskovec. Jure is an associate professor of computer science at Stanford, where he's a member of the Info Lab and the AI Lab. He's also an investigator at Chan Zuckerberg BioHub, where he focuses on developing new methods for analysis of biomedical data. Jure's general research area is applied machine learning and data science, which he applies to large interconnected systems. And some examples of applications of his work include common sense reasoning, recommender systems, computational social science, as well as computational biology, where he puts emphasis on drug discovery. Jure's research has won many different kinds of awards, including Lagrange Prize, Microsoft Research Faculty Fellowship, Alfred Sloan Fellowships, as well as multiple Best Paper and Test of Time awards. Jure has received his undergraduate degree in computer science from the University of Ljubljana in Slovenia, and then PhD in machine learning from CMU, followed by a postdoctoral training at Cornell. And with that, please welcome Dr. Leskovec, who will talk about mobility networks and their use for modeling the spread of coronavirus.
Yeah, thank you so much. Really excited to be here. Thank you, Evgeny, for a nice introduction. Thank you also for the invitation. Thank you, Madhav. Really excited to talk to you all here and show you some of our work. But more importantly, I think the point here I will try to make is how large-scale detailed data really allow us to do new kind of epidemiology, right? And this is really a collaboration between with PhD students at Stanford, Serena, Emma, and Pangwei, Jaylene, who's the epidemiologist, and Beth and David, who are sociologists, right? So this is a very kind of interdisciplinary group of people, and I will show you kind of how our thinking went. So, let's go back a year and 2 months, March 2020, there was the outbreak, right? And then there was a lot of what we could call drastic measures. Here are some examples of them. And not even that, right? Then there was a lot of information and conflicting news and a lot of different ideas how to fight the pandemic. And it was very hard because a lot was unknown. It was this new virus, first time, a lot of unclear, a lot of uncertainty, a lot of unknowns. And all this also got some, let's say, resistance from the population, because it was a lot that was put on them. It was very hard for everyone, and still is very hard for a lot of people, for a lot of subgroups, subpopulations, and so on. So it was a very challenging year, and was very challenging in to figure out what to do in this new world with the outbreak happening in real time. So what our group did is, back in March, we actually said, can we help? We are computer scientists. We can build models. We are good with large amounts of data. do we have a novel idea? Can we kind of come and help the humanity face this crisis? And we actually stopped quite a few research projects or kind of moved them towards what I'm going to present to you today. So we started working on this exactly when the pandemic happened. We are not a computational epidemiology lab or anything like that. So here is how our thinking went, right? Viruses, including coronavirus, spread through human contact, right? There is an underlying network, this contact network that modulates the spread of the virus, right? And the virus is going to spread very differently depending on what is the structure of this network, right? If the network is very densely connected, it will spread differently than the network is very sparsely connected, right? And all these social distancing measures and so on, what they really try is to make this contact network sparser. They're trying to change the medium over which the virus spreads. But if you look at the epidemiological model, the main problem kind of is that contact networks are largely unknown or severely simplified. And as I showed in my first few slides, in some sense, we don't know whether the contact network is like the one here on the left, or is it more like the one here on the right? And obviously, just that this will have huge implications on the spread of the virus and trajectory of the pandemic, depending on how this contact network looks like. And if you look at kind of modeling, baseline modeling literature, the contact networks are unknown. So kind of what do? We approximate contact networks with fully connected graphs, right? We assume this kind of uniform mixing. And that is perhaps not the most realistic assumption. And this is the assumption we wanted to challenge when we started working on this project. And then I think the other thing I want to emphasize as I start talking about what our work is that modeling is super hard. And especially modeling is super hard when the world is very dynamic, non-stationary, things are changing every day. And especially if you think about the changes in our human behaviors around the outbreak of the virus, our behaviors were changing hour by hour, right? So it is extremely hard and extremely challenging to build models because the world is so dynamic and so much changing kind of in an unpredictable ways in real time, right? From people drinking detergents or whatever, and so on and so forth, right? So the point that I'm trying to make is, right, the underlying behavior of the population is constantly changing, and making accurate predictions models is super hard. So when we started, our premise was, if we are able to estimate this dynamic human contact network, then we will be able to model the virus quite accurately, right? And not even that, if we have this contact network, then we are able to ask a lot of interesting what-if questions that at that time were largely unanswered, right? In a sense, do these social distancing measures, are they really needed? How much do they really stop the virus? If we are reopening the economy, how should we do that? And what kind of trade-offs do we face? Can we understand why different socioeconomic groups, people of different backgrounds, have very different risks for getting COVID, or very different mortality rates? Can we explain those? So that's kind of how we started. Right, so the question is, how can we accurately estimate the dynamic contact network of hundreds of millions of people? What we decided to do is to look at the sensors we are all carrying in our pockets, meaning cell phones. And based on the proximity of the cell phones, we can say if two cell phones were close to each other, this means that two people were in contact with each other. And we have decided to model 10 of the largest US metropolitan areas that have a combined population of 100 million people. And for every hour of the day, for every day of the week, every week of the month, we will infer a separate network of how these cell phones were in contact with each other. And this is just kind of synthetic data simulation to show you how these dots come into contact with each other. We have used the data that was made freely available by a company called SafeGraph that anonymizes and aggregates location data from many cell phone applications. So basically, they have agreements with many cell phone mobile application developers that then users agree to anonymize and share their data. They are aggregating it, further anonymizing it, and then making it available. This data is freely accessible, and people can download it for the purposes of research. And this is where we started. And then we said, okay, how would we develop or capture this mobility contact network? We have decided to model two types of locations. Places, which is points of interest, like restaurants, grocery stores, and pharmacies and other types of locations, as well as neighborhoods, which means census block groups. Neighborhoods are areas where about 600 to about 3,000 people live. And we are going to infer this type of bipartite network, where at the bottom we are going to have census block groups, and at the top there will be points of interest. And for every hour of the day, we are going to estimate how many people from a given neighborhood visit a given point of interest, a given grocery store, a given place of worship, and so on. So that's the idea, right? For every hour of the day, we'll know how many particles, how many people from one neighborhood visited a given specific point of interest. So we have developed this system that allows us to integrate a lot of different types of data sets, and we have developed this network inference procedure that allows us to infer this dynamic network for every, as I said, for every hour of the day, the number of visits from a given neighborhood to a given point of interest. We are modeling nearly 60,000 neighborhoods and more than 500,000 different points of interest in these 10 largest metropolitan areas. And we have over 5.4 billion edges in this dynamic mobility network. And just to show you an example of such mobility network for the Washington, D.C. metropolitan area. Here is the mobility network on March 2nd on Monday, 1 p.m. These are different neighborhoods in Washington, D.C. Here are the violet dots are different points of interest. And, a line means that some people from that neighborhood visited that point of interest. If the lines are vertical, it means basically that it was location close to their home. And when you have this kind of diagonal lines, it means they had to travel to that point of interest. And, the amount of gray stuff here tells you how many the amount of mobility. This is March 2nd. Here is April 6th. And just visually, you see the striking difference in the amount of mobility. Now, on top of this mobility network, we have developed and imposed a SEIR type model that has only 3 free parameters fixed over time. So basically, our entire model is going to be defined by 3 free parameters that are all scalars and all fixed. And these 3 parameters are the transmission constant for transmission at a POI, a transmission constant for virus transmission in the neighborhood, and P0, which is the initial fraction of infected population. And basically, the way we can think of our model, here are some equations, but essentially we are thinking that there are, we have 1 particle for every inhabitant. Particles move to points of interest according to our mobility network. In the points of interest, particles from different neighborhoods mix. The probability of them infecting each other is proportional to this parameter beta, POI, that remains constant over time. Depends also on the dwell time, so how long people tend to stay in that area, as well as what is the square foot area of the place. So basically, how big is the place? This basically allows us to account for the people density and the visit time, dwell time. So this is how particles infect each other in different points of interest, and then they go back home where they can again infect each other with a smaller background infection probability or infection transmission constant. And that's all there is to the model. And these things are fixed. They are the same for all the points of interest, and they are the same for all the neighborhoods. So the model is simple, and we wanted it to be simple because we didn't want it to have too many bells and whistles, so we can really understand. So that was the model. And then we said, okay, how would this work? So here I try to show you mobility for Chicago metropolitan area. These are the predictions of our model. Here is the map of the Chicago with different neighborhoods, and the color corresponds to the fraction of infected population. And as you can see, as this video is going, you see the mobility in terms of total number of visits to points of interest. It starts dropping around March 10, and it dropped from about, let's say, 2 million to about less than 1 million. And then you can see how our model predicts how different neighborhoods are getting more and more infected. And this is the number of people in different states according to our epidemiological model. But basically, we have a simple epidemiological model that we are unrolling over this dynamic mobility network. So after we've done this, of course, the question was, will this fit the data? Because the trajectories in different cities were very different, right? New York had a huge outbreak. Other metropolitan areas didn't have a huge outbreak. So when we applied the model, we were able to see that it actually fits quite well. So here is an example of how well our model fits. Essentially, the blue is the model prediction. Orange is the trajectory. Here is 9 different metropolitan areas. This is New York City. And then the axis, these are actually the reported case counts. So notice that there is a lot of uncertainty and a lot of noise around these case counts. And the orange line is just a guide to the eye. But you can see that the model fits okay, quite well. But perhaps more importantly, it's able to fit all these different trajectory shapes quite accurately. New York, Washington, D.C., Dallas is interesting, Atlanta is here, Miami, Philadelphia. It's able basically to qualitatively capture these very different trends that were happening across the United States. But perhaps the most important ability of this model was that it was able to answer some of the open questions at that point in time. And it was actually the first work that established quite a lot of, provided answers to quite a lot of questions that were open at that time. So for example, the first one is, did social distancing really help stop COVID, right? If you look at our traveling patterns, they changed quite drastically around March 15. This is, number of visits to different types of places as a function of time in 2020. And the question is, how much effect did this have? And what we can do in our model, we can actually have different human mobility scenarios and see and use the model to predict what would be the fraction of infected population. And basically, the point being, black line is the cumulative infections per 100,000 according to the data. This is the truth. And the other lines are projections by our model if there would be a different amount of reduction in mobility. For example, with no reduction in mobility, our model predicts or projects that 32% of entire population would be infected in a single month. This is 32% of entire population of these 10 largest US metropolitan areas would be infected in a given month. So it had a huge effect that, we stayed at home, and it was a good thing. And here's kind of some evidence for it. A second thing allows us to do is, because we know categories, we are modeling individual places of interest, we can say which are the ones that are most risky, right? If we keep going to these places as we did before the pandemic, how many infections are projected to happen there? And we find out, for example, our model gives two things. First, it shows that there is big diversity between different points of interest, that only about 10% of points of interest account for over 85% of all infections. So it means that there is, not all points of interest are the same, not all places are the same. And in particular, it's full service restaurants that would have that have the highest predicted increase in infections if they were to be fully reopened. Right? For example, then followed by fitness centers, coffee and snack bars, hotels and motels, and so on. Right? And for example, places of worship are here, and then some other types of points of interest further down the list. So this was interesting because for the first time we are able to see this ranked list and say, aha, this is the risk for if we fully reopen all these different places, and how much effect they would have on the trajectory of the coronavirus spread. The third thing we were able to establish is we are able to simulate various types of reopening strategies. And what we showed is that basically you can quite effectively reopen the economy such that you keep the number of infections low, but still keep the business. And what this graph is trying to show is the y-axis is predicted number of infections, and x-axis is what fraction of visits do you lose by mandating the maximum occupancy or a fraction of your maximum occupancy. So if you would reopen at 100%, this is where you would be. For example, if you were to reopen the economy at 20%, so let's say restaurants, grocery stores, and so on are reopened at 20% their maximum occupancy, then in this case, you are only losing about 40% of the foot traffic, but you are cutting down the number of new infections by more than 80%. So basically, this was the first analysis that showed that reopening the economy is not kind of a all or nothing, but you can reopen it fractionally. And our model, our tool, basically allows you to explore these complex trade-offs and decide as a policymaker, what do you think is good for your city, for your town, for your area. So this is kind of, I think, the point here. And then the last thing I want to mention is that we saw reports that different socioeconomic groups get hit by the coronavirus very differently. And first we were asking, does our model capture this? Because our model doesn't know what neighborhoods are rich, what neighborhoods are poor. It doesn't know any of that, right? There is no neighborhood-specific parameters. It's just the same infection probabilities. Everything is the same across neighborhoods. They just move differently, right? Their mobility is different. What we find out is that actually our model captures this disparity in infection rates between, let's say here, highest and lowest income neighborhoods. And we see that in all the cities, our model kind of predicts that low income neighborhoods have about 2x higher infection risk than high income neighborhoods. And the question is, why is that? Because before our work, kind of the working hypothesis was that in poor neighborhoods, people have a lot of pre-existing conditions. And yes, poor neighborhoods get hit by this virus much more. What our data and the model allows us to do is to get some sense of the mechanism. And first we see that one part of the mechanism is that lower income neighborhoods saw smaller reductions in mobility. So lower income neighborhoods were able or reduced their mobility less. However, we find out that this is only part of the answer. The second part of the answer is that points of interest visited by people from low-income neighborhoods have also higher transmission rates. And we find out that median transmission rate, for example, for grocery store is more than 2 times larger for grocery stores visited by low-income people than the grocery stores visited by high-income people. And then you can say, why is that? And we find out that people in low-income neighborhoods would go to grocery stores that have 60% higher density of visitors, and they stay there about 17% longer. So basically, low-income neighborhoods, what this reveals is were not able or did not decrease their mobility. And when they visited points of interest, they visited points of interest with that are more risky in terms of both density of people, and they stayed there longer. So we did this work, as I said, in March last year over the summer. We were able to publish it in Nature on November 10. And these are the three primary key authors, Serena, Emma, and Pangwei. I want to show now what happened after November. So the first thing is, this was in all over the world, over 400 news outlets, interviews we gave all over the world. But perhaps more importantly, we also created here in collaboration with Madhau's group at University of Virginia, a decision-making tool that allows decision makers to understand these trade-offs and think about how to reopen the economy in the best way. So we are working with Virginia Department of Health, Santa Clara County here locally in California, as well as, City of Dallas, Ontario, and OECD. So this was one part of impact. And then the second part of impact is that our research really impacted millions of people all over the world, that I kind of heard from friends, in Poland, Japan, and many other places, how basically their governments were using our paper or, even plots from our paper here to talk about how they're fighting the pandemic. US state governors were referring to our research, and even US Supreme Court is citing this work to establish their policies and decisions. So really, what I'm trying to say, this was very useful and really helped us face the pandemic better than we would be able to without it. So what are we currently working on? We are expanding our pipeline to include additional data, in particular using use of masks. And what we find out is that to be able to accurately model subsequent waves of the pandemic, like the second wave here, we need both the mask data, mobility data, and we also need to allow the infection probability in neighborhoods to linearly increase over time because people were started to hang out with each other inside neighborhoods. And with these additions to the model, we can get quite accurate fits. So to conclude, I talked about basically kind of the power of big data and this data that is available that allows us to sense the world around us and allows us to develop this real-time accurate contact networks between people. And this basically allows us to do so much more than what traditional epidemiological models are able to do. And we demonstrated this on a population of 100 million people, more than 500,000 different points of interest, and showed how in some sense a rudimentary model allows us to capture micro trends down to individual neighborhoods and locations, and how this fine-grained analysis can inform effective and equitable responses to the pandemic. So with this, I'm done. Thank you so much, and happy to have questions if there is time.
Jure, thank you very much. It's amazing work. One question I have for you, you talked about linking reductions in mobility to reduction in case counts. And I was wondering if you could help our listeners understand how you are thinking about the causality here, because as you have said, there was major change in the behavior of people over time. There are multiple interventions, first social distancing, then masking, then vaccines now. How are you thinking about quantifying causality here?
So perhaps I answer a few things. So first thing is we are fitting the model in two ways. One is to fit it to the case counts, and fitting it to case counts is a bit problematic because even our ability to detect cases is changing rapidly over time. We also are able to fit the model actually directly to the deaths, and that makes it fit very nicely. I think in terms of causality, right, what our model is in some sense doing based on the mobility today, it is predicting how many cases are you going to detect 2 weeks from now, right? So in that respect, we have this kind of notion, I don't know, of Granger causality, I guess, if you wanna think of it. But in some sense, what our model is doing, it's kind of now casting 2 weeks into the future, right? Because there's a 2-week delay between the being exposed or about 2-week delay between being exposed, getting infected, and showing symptoms and being able to infect others. So we have this kind of 2-week difference between the mobility today, and we show that on the mobility today, we can quite accurately say what is going to happen 2 weeks from now. Even though our goal is not really to predict, our goal was more to model.
Thank you. And maybe a more difficult question. It was very interesting to see that the behavior was changing so rapidly that you had to refeed the model multiple times. And I'm wondering if you have thoughts about actually predicting the change in behavior. What kind of world knowledge would be needed for that?
That's a misunderstanding. That was not our model. We only fit our model once. And it's fixed, and we run it through the entire time of the study, which was from March to end of May.
I see. Thank you for the clarification, but I guess my question still remains. Do you think with some amount of additional world knowledge, you would be able to predict the actual change in behavior?
That's great. That's a super good question. So what we are looking right now actually is that as a policymaker, kind of anecdotally, we heard that a lot of policymakers are trying to, there are, of course, interactions between counties, and people react differently. And, here in Silicon Valley, Santa Clara County had some policies, and San Mateo County, which is just across the street, has different policies. And then the question, of course, becomes, what do people do? And then, for example, San Mateo County had some policies about how far from your house you can go. But really what the point there was that they didn't want people to go to the beaches and congregate there, right? So this kind of policy making is very complex. And I think the way the population will react to that is even more complex. And right now we are actually building tools, trying to build some understanding about, could you predict the reaction of the population based on the policy you have decided on.
I see.
So that's a great point, because in our models and this what if analysis, we just say, oh, let's make people move differently. But the question is, what policy makes people move differently?
Thank you, Jure. And we have additional questions for other speakers. So let me ask a question of Marcel. Can you please talk a little about proximity tracing versus absolute location-based contact tracing? Would absolute location data bring more benefit in contact tracing, for example, in identifying hotspots, and is the benefit worth the additional privacy risks or trade-offs?
Yeah, I would say, ultimately it's a trade-off there, right? I mean, the exposure notification framework obviously has been very clear on the fact that no location data can be shared through these apps, and they have also enforced that, right? Famously, recently, when the UK app tried to get a new version into the Apple Store and was blocked on those grounds. I think that's, in general, a good stance to have, because once you allow that, there, all kinds of things will sneak into the app. Question whether you need to know the location to reach your epidemiological goal. We've always had the view that this is not necessary, right? What is necessary when you do contact tracing is that you manage to reach those people who should be reached. That has the epidemiological impact. That where this can later be helpful to analyze the data, but it's a different thing. And we think that the privacy trade-off is not worth it. It's important that you know who to contact because they were in the same place, but it's not necessarily important that you know where that was.
Thank you very much. And maybe another question, had you been doing it today, would you do anything differently? Would your choices with respect to privacy protection or the amount of data you collect, or where on the spectrum on epidemiology versus privacy you are? How would you think about it today?
Yeah, it's a great question. I mean, there's certainly some things that I think we would try to do differently, but honestly, it's not on this trade-off between privacy and epidemiological impact, because right, we've seen, the little gain that you would gain by reducing the privacy by a lot in terms of epidemiological impact, you can get from tons of other things. I mean, the great paper that came out today by Chris Fraser, for example, has shown, right, that, or at least estimated, but I think it's on really solid data, that for any 1% additional app usage, you get 1 to 2% reduction in cases. right? I mean, imagine normally, right, what a policymaker would do, right? Jump up in the air. If you say, I have something very easy for you to quickly reduce your cases by 1 to 2%, right? What is it, right? Where do I have to turn the knob? Well, it turns out you just have to convince 1% more people to use this extremely privacy preserving app. So before we go down the road where we say, let's start to reduce the privacy, let's first use all the other tools that we can, right? Making sure people get tests faster, free tests these days, that they can activate the app, that they use the app. There's a whole lot of things we can do before we have to start tweaking with the privacy.
Thank you very much, Marcel. It's a very insightful observation that communication and awareness can improve things drastically. And let me also ask a couple of questions of John. So my first question would be similar to what I asked Marcel. You have quickly reacted to the pandemic, and you have put together an impressive number of projects collecting and mining data. Had you been doing it from scratch today, or with a wealth of experience you collected, would you have done anything differently, if at all?
It's a good question. So there's some things that were new builds, some things that were leveraging old tools. I think that, I'm not sure how much, some of the things that we did for speed purposes, and they weren't necessarily built for scale. And so some of the initial tech that we built very quickly around some of the crowdsourcing efforts were done with an eye towards getting something out like immediately, because there was a strong data need. But then of course, once we did that, we sort of bifurcated some code bases that ultimately meant that we had to stitch things back together. Like one example, so I talked about COVID Near You, which is a crowdsourcing tool for COVID. We had a tool called Flu Near You. Flu Near You couldn't scale that well, so we worked to build a whole new code base for COVID, but then we had two parallel crowdsourcing tools, totally different code bases, and then we had to spend the summer merging them back together. So I don't know if we could have done it differently, but there is a challenge in these pandemic times where you're trying to build really fast to meet a need, and that is at the expense of things that potentially, that could be more long-term. And that's actually a little bit of a fear that I have with just the broad level of development. There's been incredible innovation I've seen throughout the pandemic, incredible visualizations and data mining and analyses, but I'm very worried about the sort of the graveyard of tech that I'm already seeing people just walk away from, which makes sense. People outside the field came in, they built stuff, now they're back to their day jobs. Totally makes sense. But like, do those contributions actually have a real impact after the pandemic, or are we gonna have to rebuild all this stuff again? And I fear that a lot of these things are not gonna be, there's not gonna be, the people that are gonna continue doing this are not the ones that are getting that knowledge transferred over. And so that's a bit of a, I mean, clearly this group here has a different bent and is trying to build things, infrastructure for future pandemics. But I have a worry that, the field got really big and it's going to contract and we're going to lose a lot of that know-how.
So maybe one important lesson for the future would be the preservation of knowledge and communication of what has been done, what worked well, and lessons learned.
Yeah. There's a frenzy of funding and then, people walk away, which, it's just expected human behavior.
Thank you, John. And speaking of the kinds of data which are useful for the management of the pandemic, you have leveraged a wide variety of kinds of data made available by Google, Facebook, and others. If you could wish for a Christmas present, what other data not currently available to you would you want? We obviously cannot make any guarantees that it would be available, but
are you offering? Is this an offer of my?
I am asking for thoughts as to what would be available.
No, obviously, I mean, some of the data that's been unlocked by large companies has been nothing short of amazing, right? The level of mobility data or survey information, the kinds of things that you guys are doing now, and then other companies are deploying at scale. I mean, these are not cheap things that you're doing. So I guess part of my Christmas wish is that, or my Hanukkah wish or whatever it is, that you essentially try to keep these things going, because, like for instance, the Facebook survey, it's the largest public health survey by far ever done. And there's a lot of interesting insights, but can that continue well into the future? I don't know. obviously I'm super interested in being able to link the data that we get through these tools to genomic information and testing data and all this other information that's sort of being lost. I mean, now we have a deployment of all these rapid tests across the country. Where is that data going? It's not going into anywhere, right? It's just, you know, people are using it to make decisions for themselves, but that data is not ending up anywhere useful. So figuring out how to take some of that testing and other data and bring it into this infrastructure would be phenomenal. But, you know, again, like if we just can continue what we're doing now, that would be good enough.
Thank you, John. And I see here a couple of additional questions for Jure. So the asker appreciates your interesting findings on the SafeGraph data and asks, would more fine-grained mobility data, either spatially or temporally, such as, for example, trajectories in addition to the visits, would allow better modeling? I assume it's a general theme on what other kinds of data or what additional filicity in the data would be useful.
Yeah, so for example, I would say, you know, we aggregated to these levels of points of interest and neighborhoods. You could go more fine-grained. I think it would help. How much it would help is a good question. I think what it would also, for example, help is we realize that the data we have is not perfect, right? It doesn't include certain populations. So, for example, you know, kids are not part of the data. So, for example, in our work, we didn't say anything about schools. We intentionally decided not to make any claims there because we felt the data doesn't allow us to do that. Another thing, for example, in the model is we don't know the age of the people. Right, so the age was another, like there were a lot of kind of age-related effects. So, for example, having that, I think would be really cool. So, I think basically the way perhaps I would look at our work is, in a sense, if you want to do decision making in uncertain, unpredictable world, you need good real-time data. And I would look at our work just as a showcase or as an example of what is possible with the data that essentially we have today. And you know, of course, there are privacy implications and things like that that we all have to be mindful of. But it allows us to respond to the crisis in real time in some sense.
Thank you. And there is another technical question: how do you verify the number of infections at different points of interest which are predicted by your model?
How do we validate? These are predictions. We can't really validate them. I mean, we can validate the reported case counts at the level of zip codes, for example, or at the level of counties. That is what we can validate. And then what we did, for example, for the model is we looked at what was known, published in the literature about density of the people, dwell time, and things like that, and we included those parameters and those constants into the model. But you know, those are purely predictions.
Thank you, Jure. So I think this concludes our session. Let me thank very much the speakers again, Marcel, John, and Jure, and thank you also for kindly addressing all of the questions. It will definitely inform our preparedness for future pandemics. Thank you very much, and I'm looking forward to seeing you in real life one day.
Thank you so much for the invitation. It was great.
Thank you.
Thank you very much, folks. Bye.
Thank you.
Thank you. Bye-bye.
Thank
Have a nice
you.
day.